back from exam 1. So this week we're going to go over chapter 21, which is the hospital experience for the child. So there's a brief PowerPoint, and then we're going to do a Kahoot, and you guys will be free to go. Does anyone have any questions about anything before we get started?
Yes, we're gonna meet after class so I can show you the thing.
Yeah, Walter, when we're done with class, go ahead and stay on, and then you can share the computer screen with me, and we'll come up with a plan for you, okay? Does anyone else have any questions? Okay, so I'm going to go ahead and start, sorry, I'm tongue-tied here, start sharing my screen, and we'll go over the PowerPoint to start with. So chapter 21 is the experience of the child in terms of the hospitalization. Minimize this. Okay, so there's very specific, we'll go over some details here, but the main thing is, to think about the different ways or the different places that children get healthcare. There's a very specific process that can happen to children that is called separation anxiety, and this is specifically in terms of being hospitalized. So it's a little bit different than the separation anxiety that we talk about generally. And we're going to talk about, what you as a nurse can do to make the process of being hospitalized easier for the parents and the children. And then talk about, how being a toddler or a preschooler, how that kind of where you are in that developmental stage contributes either positively or negatively to being in the hospital. So I think all of you know this, but we focus a lot on sort of the outpatient clinic, like where they go for their well child checks and their immunizations, in the hospital. But there's a lot of different places where kids can get care. So there's the hospital. Sometimes kids are in long-term care facilities. For example, kids that are trached and vented, it's not that unusual for them to live in a long-term care facility. They also can go to urgent cares, the outpatient office. Sometimes there's research centers, for example, if they have like cystic fibrosis or they're have sort of cancer and they're in some experimental drug. Sometimes they're outpatient surgery centers, and then children are at home and they can have home health nurses that come to their house to help them with their care. So these are obviously the different age groups that we're talking about. And, depending on their age and the developmental level, you're going to tailor your nursing care so that they are getting the information that they need in a way that makes sense to them. So who can tell me how you would treat a toddler different than, say, a school-age child if you were going to explain to them they're going to get an IV?
You need to explain procedures in ways they understand.
Right. So how would maybe a toddler understand differently than as like a 6-year-old?
Toddler can't comprehend quite as much as a 6-year-old.
Sure. So yeah. So, and you can, you can use like a doll or something and show them. I think that would be even more important, like a young kid, like a 6 or a 7-year-old. Maybe they've been in the hospital before, or they have some experience. So you could kind of be like, oh, we're going to put a straw in your vein, and this is the vein on your hand, and you're going to feel a little poke. But a toddler, you might want to like bring a doll in and be like, okay, so this is Betty, and she has a hand just like your hand, and we're going to put a little straw in there and show the toddler on the doll. You can still use dolls in school-age children, but like you said, school-age children are going to be a little bit more understanding, but you might want to be able to use some objects or something like that with a younger kid to kind of show them what's going on. And then an adolescent, they're gonna be able to just understand you the same way that an adult would. So when we talk about the hospitalization, one of the things that we really focus on is separation anxiety. Obviously, kids are home with their parents most of the time, and then when they get sick and they have to come to the hospital, that can be really traumatic for them. So we talk about separation anxiety, generally speaking, around 6 months of age, 6, 7, sometimes kids really start to freak out when they're not being held by their mom or dad. But it is a little bit different when they're in the hospital, right? Because maybe mom and dad have to work and they're not going to come back. So like if you're at home and your kid's healthy and your kid screams because grandma's holding them and they don't really know grandma that well, you can sort of deal with that situation because you're still there. But if your kid is in the hospital and you have to leave to go to work, then there's more trauma and the kid's gonna potentially be more impacted by that. So there's these 3 stages. There's protest, despair, and then denial or detachment. So protest is the kid is screaming, they're screaming for their mom and they want their mom or their dad to come back. Despair is they've kind of realized that crying for mom or dad isn't going to work. Mom and dad is not going to come back. And they're just kind of sad and they're not really interacting and they don't want to play. And then denial or detachment, they're playing with their toys. They've kind of reached the point that they're like, whatever, I'm sad and I'm not going to get what I want. So sometimes parents really have a hard time with the denial or detachment phase because they'll come to visit their kid and the kid's like playing and they won't look at their mom or dad. They're like totally cut off. They're like, I'm just going to ignore you because I'm mad that you left me here. And so sometimes parents have a really hard time dealing with that. So it is a normal process that kids will go through as they're separated from their parents for a longer period of time. And you're going to go into this in your book some more, but when we're talking about the hospitalized child, they usually move through all of these phases unless the parent can be there with them. Because like I said, some parents have to work. So if that's not true and the mom and dad are going to leave the kid alone in the hospital all day, they're going to kind of progress through these stages. So like I said earlier, usually the one that's the really, really hardest for the parents is when they get to that denial stage where they don't want to interact with the parent when they come to visit. So what do you think you do as a nurse if this is happening? If the mom says something like, well, maybe I shouldn't even come because she doesn't seem to care that I'm here. Is that true? Should the mom just stay away, or how should the mom react when the kid acts like she's not interested in the mom being there?
She should still go visit. She
Yeah.
should attempt to interact with the child.
Mhm.
The child doesn't want to give her space and wait for her to come to her.
Okay. Yeah. And also try to explain that this is, kids kind of go through this. This is their defense mechanism for dealing with the trauma, right? But the kid really wants you here. And encourage the parents to be there as much as possible. Like, as a nurse, you have to be understanding that sometimes parents have to work. Okay. We can't judge parents that aren't able to be in the hospital when their kid's in the hospital. But if at all possible, they should be there as much as possible and try to get social work involved, try to help them problem solve, kind of rearrange their personal life so they can be there as much as possible, because even if the kid is acting like he or she doesn't care, the kid does. So obviously how the kid reacts to being hospitalized is going to depend on their age. If they were prepared, like if you told them they were going to have surgery and they were starting to plan for it in advance, how they're dealing with stress at home, if they've been in the hospital before, all of those things are going to influence whether or not they're really stressed out with being in the hospital. And then, we talked about kids kind of preschool age, they have this real fear of their body being harmed. So that can add to those fears. Like you're in there, IVs are painful, blood draws are painful. Maybe they have to have procedures that they don't want. And that just kind of builds on their fear that something bad is going to happen to their body. So you have to be aware of that because when kids are fearful, it makes them harder for them to trust you. I think that makes sense. And we talked about as a toddler, this is where they're really learning autonomy and self-control. And now all that's being taken away from them. Like as a 2-year-old, you want to do everything for yourself. You want to establish your independence. And then you go into the hospital and you don't have any say about whether or not you get an IV. And maybe you have to wear a diaper because you're too sick to walk to the toilet or something like that. These things that you normally control at home are being taken away from you and you don't have that same sense of autonomy. So that can be really hard for kids, and it's important to like recognize their developmental age and why it's hard for them, and then try to also educate the parents about why it's so hard for them to be in the hospital. So it's not unusual for children to regress. So for example, a kid that stops sucking her thumb and then she's in the hospital, she'll be sucking her thumb again. It's like a defense mechanism that's trying to help her cope with the fact that she's in the hospital. So normally their behavior will go back to the level that it was once they're out of that stressful situation. So there's certain things we kind of talked about their developmental age. Obviously sometimes being in the hospital is painful, so you have to have different techniques for assessing and managing pain in different age groups. If they don't speak English, you need to make sure you have an interpreter, and if they're deaf or their parents are deaf, they have sign language interpreters also. Do you think siblings should come visit? Is that a good thing or a bad thing, generally speaking?
It's a bad thing.
It's a bad thing, Walter. Why is it bad?
The kids, we get that a lot in my place. Like they bring this, they have a child in the hospital and they bring the other siblings, not knowing that they can bring home other stuff that you don't want. So it's like, kids, they touch everything, they get on the floor. It's like, we don't recommend it, but sometimes parents don't listen. So it's like,
yeah. So I can say from a developmental standpoint, for a lot of kids, it's helpful. Like if you're an older sibling, you're 5 or 6, and your baby brother's in the hospital, it can be good for the kid to see that the kid's actually okay, to come in and see. I agree with you from an infection standpoint. They could bring something new in, or the kid could have RSV that's in the hospital and they could bring that home. So from an infection standpoint, that's true that it's not recommended. From the kid's psychological perspective, though,
yes,
a lot of kids like feel better once they come in and see their kids. So if you're only looking at it from the developmental level of the sibling that's at home, coming in and seeing them. But it is a lot of, I worked in a children's hospital and we wouldn't allow kids in during respiratory season. Only adults could come in to visit. So from an infection standpoint, that's true. But if you're simply looking at it from the child's perspective, it's good. And then we talked a little bit about this. There's different ways that you assess pain in kids. And I think I asked you guys before. So can you guys tell me some pain scales that you use in pediatrics?
Black.
Black. Yep.
Faces.
And somebody said something else?
Faces scale.
Faces. Okay. So yeah, and you should, most of the time where you work, it's going to be built into the electronic medical record, and you'll pick your pain scale and you'll go from there. So sometimes kids cry because they're in pain, and sometimes they cry because they're scared or anxious. So you do need to be aware of how kids behave when they're in pain. So other than crying, what would a kid do when he or she is in pain? A toddler or a young child?
They might like hold that area. Like if their stomach hurt, they might hold their stomach.
Very good. Sometimes they're just not as active. They're just kind of laying there and they're kind of stiff and they don't want to move. Sometimes you'll really see it in their face. Maybe their brow is furrowed. What sorts of vital sign changes might you see with pain?
Heart rate increase.
You can see increased heart rate, increased blood pressure sometimes. So, try to get a whole picture when you're assessing pain. So, these are some non-pharmacological techniques that you can use. Obviously it kind of depends on their age. A 2-year-old isn't necessarily going to draw too much, but a 4 or 5-year-old would. So just think of, how to distract them, some age appropriate techniques to kind of keep their mind off of what's going on. So we talked about this last time, and for the last test, that kids, they're a higher risk for drug toxicity because of their metabolism, their kidneys, their liver, their GI tract. So, we're always going to do either medications based by weight, or what's the most accurate way that we can deliver medications, the most accurate way of determining the correct dose?
The body surface area.
Body surface area. Very good. So we generally speaking try to stay on top of pain, so you don't, it's harder to get pain under control once it's really bad. So you can usually use lower doses if you give it around the clock. So if you're giving Tylenol every 4 hours, and you're preventing the pain from getting really bad, you're going to have an easier time controlling the pain, versus if you wait 8 hours and then the kid's in a lot of pain, you might have to give a higher dose or give multiple medications. So there is a very specific procedure called conscious sedation. Who works in a hospital right now and can tell me what conscious sedation is?
It's a sedation that they use, but the patient's still awake, sort of.
Yeah, so a lot of times they use something like Versed or something that kind of makes them unaware, but they're still breathing on their own. So if they
Yeah.
do give a pain medication, it's not going to be to the point that they're not breathing effectively. At least that's the ideal situation. So they, if you're under a lot of sedation, they have to put an ET tube or a breathing tube in you. So conscious sedation, they're generally awake. And breathing on their own, but they need one-to-one monitoring because they are getting medications that can affect their respiratory rate and their vital signs. So it's usually, conscious sedation usually happens more frequently in like an emergency room or an intensive care unit. It wouldn't be common to do it on the floor, and they will need just one nurse to monitor them during and after the procedure. And there's a whole like checklist that you're going to see in your electronic medical record for documenting everything when they undergo conscious sedation. So why do you think someone like why would a kid need conscious sedation? What sorts of procedures would you use conscious sedation for? Would you do it to place a Foley?
Fully.
No, so they're not going to get anything for that. Would you do it to place a chest tube?
Yes.
Yes. Okay. So something that you really need them to hold still and might be painful, you would use conscious sedation. Chest tube, sometimes PICC lines, depending on how much they move around, a central line for sure. So chest tubes,
I think we
etc.
have to do it also for spinal taps. Sometimes it's like,
Okay, yeah, you might do it for a spinal tap, but it's usually if they're old enough to follow instructions, you can just get them to kind of do it, sit still. But yeah, something like that where it's really, really important that they sit still. And we briefly mentioned, that you should be using language interpreters. So for those of you that work in the hospital, do you have physical interpreters that come in, or do you have to use the phone?
we use a phone. It's a translator system.
Right. So they have a bunch of languages on that phone. Like I've used Somali, I don't know, languages that I've never heard of. So yeah.
The one hospital we do clinical at right now has like an iPad and they'll go on. So it's like still a visual, but they're it's like a FaceTime pretty much. It's really, really cool.
Wow. That's amazing. That would be really good because I've struggled with using the phone before. I feel like a lot gets lost when you can't see how the interpreter is reacting or something like that, or you can't really tell if they've understood everything. So that's awesome that they have the iPad so the patient can sit there and talk to the interpreter. That's amazing.
I use those a lot.
The iPad or the phone?
Yeah. Both. I have the
Okay.
language line as well as they have like a stand-up one that you can actually take it through the clinic.
Oh,
And
okay.
you just call them up and you call the person up, and whatever language you need, they have, sign language. They have all of that. So it's pretty good.
It's pretty good. Yeah.
Mhm.
So it's great that you have those services available because it helps so much it's not just their language, it's also their culture. So it's
Mhm.
really good that and that you feel like you trust them. So that's awesome. So in addition to the language, looking at nonverbal cues and also recognizing that different cultures are different. So can you guys give me an example of a culture that might not want you to look in their eye?
Isn't some Jewish men won't make eye
Some-
contact with you.
Yeah, yeah.
And,
Yeah,
Native
go ahead.
Americans.
Very, very good. Those are some cultures that we don't talk about as often. And sometimes people from like Korea, sometimes Southeast Asia, they might look at the floor when they're talking to you instead of making direct eye contact with you. And they're not trying to be disrespectful. That's just how they communicate. They might want more personal space. They might not make as much eye contact. So, generally speaking, wherever you're going to be working, there probably is going to be a culture that you'll interact with frequently. So it would be good to know some different techniques for interacting with those specific cultures. So we briefly touched on, different people, sometimes Hispanic people don't have a smaller personal space. They might sit closer to you than somebody else's culture, or they might smile more than Asian people. So just kind of recognizing that, how much personal space they smile, eye contact, how much they touch you, all of that can be dependent on their culture. And so to try to recognize what those different differences are to make sure that, the communication that you're having with them is appropriate and they're learning what you need them to learn. So, whenever we're talking about kids, we're always also talking about the family. So there's the child's response to the hospitalization, and then there's also the parent's response to the hospitalization. So sometimes it can be really scary for parents. Obviously, their kid's sick or something's going on. So they might have a hard time with it, and they might express those fears to the nurse. So just always try to be non-judgmental and use therapeutic communication and try to give them a safe space to vent. And then recognize that if you're not really communicating, not just with the kid, but with the parents, that can add to more fear and discomfort with the hospitalization for the entire family unit. So obviously, nurses are hugely important to, the child's hospitalization. So it's not just their physical needs, it's also their emotional needs. And always think about their developmental level. A 4-year-old isn't going to understand everything's going to happen in surgery. So using really short, direct terms and explain to them that you're going to leave your room and you're going to go to sleep, and then you're going to come back and you might have a little owie on your belly if they're going to have abdominal surgery, but not going into a lot of details about what's going to happen because they're not really going to understand, and it could lead to unnecessary fear. And this is sort of, getting into more of the different age groups, recognizing the adolescents, they might still have some fears and et cetera, but they're going to be easier to communicate with since they can really understand you. And then always, always, always remember that discharge planning really begins at admission. So whenever your patient comes in, you got to be thinking about what you're going to do to get them out and make sure they're safe at home. So obviously for both the kids and the parents, this can be a really frustrating time. No one wants their kid to be in the hospital, and it adds a lot of stress to the family unit. So daily schedules are disrupted, but as a nurse, one of the things that you're going to try to do is maintain the home routine as much as possible. So that's one of the things that you can do to help transition in the hospital. So if a kid goes to bed every night at 8 p.m., you really want to try to get them in bed every night at 8 p.m. when they're in the hospital. If they eat at a certain time, you want them eating at the same time in the hospital. So you really need to get that information from parents so you can try to recreate the home routine as much as possible. And like I said, you really want to encourage parents to be there. Does someone have a comment about maintaining the home routine in the hospital? Okay. If at all possible, parents should be there. If at all possible, we would do what's called primary nursing. So if a kid is going to be there for 2 days, I mean, it's not that big of a deal. But if you have a kid that's sick and they're going to be there for a week or so, it's really nice if they can always have the same nurses so they kind of get to know their caregiver. And a lot of times nurses can sign up to be someone's primary nurse. And then that nurse knows them better. They're more able to communicate with the medical team. So, as you're getting older, talking more about adolescence, education, you focus a lot in the younger kids on educating the parents, but when you're, school age, getting into adolescence, you're also really educating the patient, and encouraging them to be involved in their care, et cetera. So for like an adolescent, should they be checking their own blood sugar? Or do they need to show you that they know how to manage and check their blood sugar? What would you do if you had like a 13-year-old that was just diagnosed with diabetes? What sorts of teaching would that 13-year-old need?
I would teach them signs of what they need to look for and worry about. I would not
Yeah.
have them taking their own blood sugar.
You wouldn't have them taking their own blood sugar. Okay. So they can start, they probably still need supervision, but they can start checking their own blood sugar, and they're going to have a little bit more sense of control if they're the one poking their own finger, because sometimes it's more painful if someone else does it. So they can start learning how to do it themselves. They're not going to be able to have full independence, but you can start teaching them, and knowing the signs is great. But they can also start learning, they're not going to be injecting themselves, but they can start learning what insulin is, why they need to take it, and start, so as they progress through adolescence, they're able to do more and more in terms of management of their disease. So are all patients always in a private room, or do sometimes they have roommates?
Sometimes I have roommates.
All right, Walter. So how do you make a decision about who goes together?
Well,
If you're the charge nurse.
no, they have to be compatible. We put them mostly with the same diagnosis together and stuff like that.
Okay.
Non-infectious disease and stuff.
Yeah, so you try to do age. It's not always possible, but it would be kind of a, you don't necessarily want like a 15-year-old with a 2-month-old.
Right. No.
And then also, like if there's two that both have respiratory infections, not ideal, but you could put them in the same room if they both have flu.
Yeah, it depends.
You,
I mean,
yeah.
We have to figure out what kind of, if one has rhino and the other one has Kawasaki. But it plays a whole thing, we have to make sure that they're compatible to put them together.
Yeah. So generally speaking, you put them together based on their type of isolation. And if one of them has like Crohn's disease, but they're not infected, but they're having a Crohn's flare up, you don't want them to put them with somebody who has an infection, especially like if they're immune compromised and they could end up getting that infection. So you generally put, two patients that have the same sort of infectious process together, generally the same age. And then if one doesn't have an illness, you don't want them with anyone infected. And certain things like TB, where you need airborne precautions, you're never going to put someone that has like TB precautions in a room with somebody else. And you need to remember as a nurse that sometimes teenagers are emancipated minors. They can sign for themselves. So it's always important to know who the legal guardian is, if it's the parent, a foster parent, a grandparent, or the patient, his or herself. And like I said, you're always going to be doing discharge planning as soon as they come in. You always need to make sure that you're saying it and that they're getting that information in writing, and they need to sign their discharge instructions when they're going home to confirm understanding. So we talk a lot about anticipatory guidance in pediatrics. So help parents understand that children are going to go through trauma being separated from their parents. So they might regress, they might be more clingy, they might have more emotional needs just because of the fear of hospitalization. Make sure that you're consistent, you have clear boundaries. You can try to distract them through play. Play is really important for kids. So having age appropriate sorts of activities that you can use with them can kind of help the hospitalization process easier for them. And we talked about this, always make sure that you know who the legal guardian is, and making sure that you're giving them all the information that they need. And when they're going home, they have a safe place to go, they have transportation, they have their medical follow-up appointments scheduled. We would make them go to the pharmacy and bring the prescriptions in and tell us how they were going to give the medication. So making sure that they have the medications, they know how to give them, they don't have any questions about storage, etc. And then sometimes they do have home care. So there are home care nurses that can come to the house and help with any procedures, or maybe kids need weight checks at home, or they can provide respite care for caregivers. So that is an overview of chapter 21. Does anyone have any questions about that? Okay. If you don't, then I'm going to just stop sharing my screen briefly while I pull up a Kahoot. We'll do a Kahoot and then you guys are going to be free to go. Sorry, my email's been a little bit slow here where I saved my Kahoot. No.
What? Oh, they are done, yeah.
Stop it.
Okay, I'm gonna go ahead and hit start, unless someone's trying to log in right now that hasn't had time yet. So which child would have the most difficulty in coping with separation from parents? A 16-month-old, a 3-month-old, a 4-year-old, or a 7-year-old? Yeah, very good. So this is kind of getting in your toddler years. You know, a 4-year-old is going to be a little bit more able to understand, and a 7-year-old certainly. And the 3-month-old is not necessarily that aware. They don't start with separation anxiety till around 6-7 months. So a 2-year-old has been crying constantly for his mother since he was hospitalized 3 days ago. This behavior is what? The toddler feels abandoned by his mother. There's poor mother-child bond. The child is not adjusted to the hospitalization, or the child is not separated from his mother often. Yeah, so this is the child feels abandoned by his mother, and that's a normal process. So it is possibly true that child is not separated often from his mother, but it's normal for a 2-year-old to cry constantly when they're separated from their mother. So the best answer is the red. So which statement best corresponds to a preschooler's understanding of hospitalization? I have a cast because I broke my leg, a germ made me sick, my tonsils are sick and they have to come out, or I got sick because I was mad at my brother. So this one was a little bit trickier. You know that this is the school age or the preschool years. They're still really into that imaginative thinking. They haven't like entered that concrete thinking of the school age child. So they don't really understand cause and effect. So like these other ones, I have a cast because I broke my leg, or my tonsils are sick, or a germ made me sick. That's more school age. So a preschooler doesn't really understand. They think that things that aren't related are, because that's intuitive for them. So the best answer is I got sick because I was mad at my brother, because that's kind of where they are at cognitively. They don't understand cause and effect, and they don't really have those concrete logical thought processes yet. So the toddler seems more interested in her toys than the parents. What stage of separation anxiety is this? Is that denial, despair, attachment, or protest? Right. So that's the denial stage. So the protest stage is when they're crying out. And the despair stage is they're not really playing, they're just kind of checked out. So this is the denial stage, where she's going to really focus on her toys, and try to just ignore the fact that she's upset. So which roommate would be the most appropriate for a 16-year-old adolescent with cystic fibrosis? A 15-year-old with type 1 diabetes, assign the adolescent to a private room, a 10-year-old with sickle cell disease and a vaso-occlusive crisis, or a 4-year-old that had an appendectomy? Good. So yeah, this is the same age, and you know, we don't really know why the kid with cystic fibrosis is, but this, hopefully there's no cross contamination, and you're not going to always be able to give them a private room, and the kid with the sickle cell disease could be immune compromised, so that's not a good option. So parents of a hospitalized 9-month-old infant ask if their preschool child may visit his younger sibling. So preschoolers need to visit to reassure himself that the sibling is okay. The sibling could view the infant from the doorway, or preschool children can be disruptive, or seeing the younger sibling would probably be frightening. So you're thinking of the best case scenario for the preschool child. Yeah. So ideally, yes, but all of these, we talked about infection and stuff like that, but from the perspective of the preschooler, it's good for them to see that everything is okay with their sibling. So a hospitalized toddler was drinking from a cup at home, but now refuses to drink anything but his favorite bottle. What is that? He's exhibiting normal behavior for his age. He's demonstrating attention-seeking behavior. His refusal is to get attention from or to avoid painful procedures, or it's a normal regression. He's dealing with the anxiety of being hospitalized. Yeah, so that's normal, and you would expect him to go back to drinking from a cup once he's over the stress. Okay, select all that apply. A nurse encourages a school-age child to draw a picture after a painful procedure. Why? To encourage quiet play, to distract the child from thinking about the pain, providing a way for the child to express his feelings, or attempting to reestablish rapport. So yeah, drawing is really important, and it does provide them children a way to express their feelings, and it can be distracting. And you know, I don't, in terms of attempting to reestablish rapport, like you should still have rapport, and encouraging quiet play is not really the whole point of drawing a picture. So the two best answers are the yellow and the blue. I do understand why some of you would have been drawn towards the attempting to reestablish rapport, but you should, you should really be continuing that conversation. You don't necessarily need to reestablish anything. When is the best time to begin to prepare a 5-year-old for surgery and hospitalization? About 4 days before surgery, on the night before admission, as soon as the surgery is scheduled, or about 2 weeks? So this one is kind of tricky. 4 days gives them enough time to sort of start processing it. If you do it the night before, that can be scary for them. As soon as it's scheduled, they're not going to really be able to think that far in the future. And that's the same thing with 2 weeks. Like that's just a really long time frame for a 5-year-old. But 4 days, they can sort of conceptualize and think about what's going to happen in 4 days. You can tell them and start preparing them. You're going to go in, you're not going to be able to eat anything for a few hours. You might have a straw in your hand for IV fluid, stuff like that, so that they are mentally prepared when they go in. So a 13-year-old girl has been hospitalized for the past week. What do you think the girl's biggest concern is? Her appearance, loss of control, separation from her boyfriend, or the fact that she's going to be having invasive procedures? Okay, so her biggest concern, given that she's kind of an adolescent girl, is probably going to be her appearance. This is one of those things that, she may or may not have a boyfriend, invasive procedures. This is probably more of a concern for a school-age child that has that sort of fear of bodily harm. And loss of control, that's, all kids might feel that, but more in the younger kids. So appearance is kind of like the thing that you think about for a teenage girl. So the nurse notices that the mother of a child with CP redoes many of the things the nurse does. What is the nurse's best response? I'm doing the very best job that I can with your child. Would you like to do all of your child's care? Go have coffee. You're exhausted and you need to take a break. Or I'd love you to share with me the special things that you do for your child. Yeah, so the best answer is, recognizing that the mom really loves her child and has very specific things that she wants for a child, and kind of encourage her to share those things with you, and try not to be offended by the mom's behavior. So a toddler cries when I visit, my toddler cries, maybe I should stay away. What's the nurse's best response? It might be easier if you would stay with him. The decision is yours. Perhaps you are right. He only gets upset when you have to leave. This is common reaction when they are separated from their parents, or we take good care of him and seems fine when you're not here. Yeah. So, making sure that they recognize that this is a common reaction. You do want to encourage them to stay, but also if the mom's concerned, make sure that she understands that this is a really common reaction and encourage her if she can to stay. So you're preparing to collect an admission history from a parent who have immigrated from Russia. What things do you have to keep in mind? Smiling is inappropriate in a serious situation. Touching the child's head means the nurse is superior. Staring is a sign of the nurse's rudeness, or eye-to-eye contact is considered disrespectful. Yeah. So, and we didn't go into specifically talking about Russia, but just in general, it's like a more stern culture, and they might think it was something was off with you if you were smiling a lot when you were discussing something serious. So, which nursing action would facilitate rapport with the child when the child's parents during the admission process? Answer questions in a calm, matter-of-fact way, express concern about the seriousness of the child's condition, perform assessments and ask questions as quickly as possible, or direct the parents to undress the child. Yeah, so good job. Kind of stay calm, be really matter of fact. That kind of helps smooth things over and helps them trust you. So a 4-year-old child begins to cry when his mother tells him it's time for his operation. Which particular fear is this? Restricted mobility, loss of control, unfamiliar routines, or invasive procedures? Um, so I, there's a lot of different things going on with this question. So I'm going to be honest, I'm not the one that wrote this. So I understand why several of you chose different options here. I mean, particularly he's going to have an invasive procedure, but the kid's also probably concerned about loss of control and the fact that it's unfamiliar. But since it says what particular fear, the particular fear is the invasive procedure, but all of these things are things that the 4-year-old is going to be worried about. How do you know the parent understands a hospitalized toddler's need for transitional objects? The stuffed animal makes him secure. He insisted on bringing his dirty old blanket with him. I'd like to get him some toys from the playroom, or I'm going to buy him a big stuffed animal from the gift shop. Yeah, so a transitional object is going to be an object that the kid has from home that helps the kid feel more secure, and they're really important for a toddler. So this stuffed animal, or they might be, the stuffed animal makes him feel secure. The mom understands whether he really needs the stuffed teddy bear. And he insisted on bringing this dirty old blanket. I mean, that's probably true, but that's not the parent really understanding why the blanket is so important. And, he's not going to be as interested in toys from the playroom, and a big stuffed animal from the gift shop is not going to be as important as whatever stuffed animal he has at home that he really likes and helps him feel secure. What is the advantage of fentanyl for an upcoming procedure? And what would the nurse say? It has a rapid onset, it's specifically designed for children, it has a long duration, or it is non-addicting. So it does have a very rapid onset. It has a rapid onset. It doesn't have a very long duration. It is addicting, and it's not specifically designed for children. It's used in both children and adults. So the nurse shares information and timelines recorded on the interdisciplinary outline of care. What is this document? the holistic care approach, the clinical pathway, comprehensive nursing care plan, or incorporated cost analysis. Right. So the nursing care plan is going to be more focused just on what the nurse is going to be doing and the nursing diagnosis, but the clinical pathway is going to be the interdisciplinary document. So the nurse is preparing to start an IV on an infant admitted to the pediatric unit. What intervention is appropriate? Let the child examine the equipment, suggest coping techniques, provide a simple explanation to the child, or involve the parents. Oh, very, very good. So you guys needed to recognize this was an infant, right? So these other techniques are not really going to be appropriate because it's an infant. So involve the parents. Very good. So another select all that apply. What will the nurse include when documenting the discharge from a pediatric patient? Adults accompanying the child and the relationship to the child, the condition of the child, the time of discharge, method of transportation, instructions that were given to the physician, and written discharge instructions were given to the parents. Right. This green one was kind of a distractor. You're not going to be giving instructions to a physician, but these other things are all things that you include in the when you're documenting the discharge. All right, last one. Select all that apply. What are the basic fears of young children about being hospitalized? Body intrusion, cost, separation, and pain. Right. So kids aren't really, they're not thinking about cost, but the other ones are on their mind or logical for them to be upset about. All right. Gabby, Marissa, very good. All right, Peyton, nice job, everyone. So at the end of this class, I'll go ahead and put a copy of the YouTube link to watch the lecture in the Kahoot and a link to the Kahoot if you want to practice it in class. Does anyone have any questions? No? Okay. If you don't have any questions, you're free to leave. And then Walter, go ahead and stay on and we'll talk about your homework assignment.
Are you able to see my screen or no?
So Walter, I have myself on mute. I'm sorry. So I am not able to see your screen, but I
because
think that you're right.
You're sharing. So while you're sharing, I cannot share my screen.
Okay.
All right, let me see. No.
Okay.
Got it. All right. So